start, I'm going to ask Associated Professor Michael Gold to come and give us a speak, and then we take the questions. Mike Gold is a pediatric allergist and immunologist who holds the joint position in the discipline of pediatrics at the University of Adelaide, and is medical unit head of pediatric allergy and immunology at the Women's and Children's Health Network. He has a clinical and research interest in the prevention of childhood food allergy and vaccine safety. He has been appointed as an expert advisor to national and international committees, which include the WHO Global Advisory Committee for Vaccine Safety, the Commonwealth Department of Health and Aging, the TGA, the ASCIA Anaphylaxis Working Party, and the Center for Research Excellence for Food Allergy. That's enough. So I think if there's any question, you can pass it on. It was a bad
thanks for the invitation. And I've enjoyed the talks immensely. It really does show that both for CMV and Zika, how important the vaccine and developing a vaccine will be. And thanks to Lynn again for covering the pertussis. So this talk's going to be a little bit different in a way, because I'm going to entertain you, because I'm going to give you a sort of very broad overview of immunisation in pregnancy. So what I want to cover is a bit of the history and the rationale of why we would bother delivering immunisations in pregnancy. I'll cover a little bit on influenza. Pertussis has been covered, but I really want to really emphasise the efficacy and the safety of delivering these vaccines in pregnancy. And I'm going to talk a little bit about safety surveillance, because that's a particular interest area of mine. So take-home message, I think, has already been delivered. I think we should all be promoting immunisation in pregnancy, obviously with these vaccines. Immunisation, as we all know, starts with smallpox. And smallpox is a congenital infection. And if you visit the Hunter Museum at the Royal College of Surgeons in England, you can actually see the specimen, which is from a fetus, and it shows congenital smallpox. And it was actually sent to Edward Jenner to demonstrate this. And we know this is where immunisation started, that you really induce a cowpox infection, which is live and attenuated, and that protects you against smallpox. And that is where it all started in 1796. So this depicts Jenner immunising. I'm sure he got informed consent beforehand. An 8-year-old boy called Phipps, and subsequent to that, he inoculated a child with smallpox to really demonstrate the efficacy of this. Immunisation in pregnancy, I'm going to talk about two aspects. The first is protecting the infant, and the other is protecting the mother. And in fact, it was in 1879, 83 years after Jenner's experiment with vaccination, that it was recognised that infants born to vaccinated mothers were protected against smallpox. So if we talk about immunisation in pregnancy, it really goes back to the start of immunisation, and it's recognised really from then onwards. In terms of immunisation protecting infants, of course, this has been done for decades, and it's been done for decades with protection to obviously prevent neonatal tetanus. I've only seen 2 cases of tetanus in my career. One in Adelaide, a 3-year-old, I think Celia knows the case as well, a child who was completely unimmunised because the parents were conscientious objectors, and that parent presented to the GP saying, "Could my child have lockjaw?" And in fact, the child did have lockjaw. That child was admitted to ICU, given tetanus immune globulin, and parents still refused to immunise the child. So neonatal tetanus really has been a huge success in terms of immunising mothers to prevent it. So in this line here, you can see the immunisation rates, I guess, for maternal immunisation, and here are the rates falling for neonatal tetanus. So in 1998, WHO estimated there were close to 800,000 newborns who died of neonatal tetanus. In 2010, 60,000. In 2014, there is still, obviously, in many countries around the world, is neonatal tetanus. So it's still an ongoing issue, but not as severe. Protection of the mother. This is the second reason, obviously, why we should immunize mothers. And I just want to make one point, but I've just chosen this quite old study from 1986 to demonstrate this. And this is the risk of acute respiratory disease amongst pregnant women during influenza A epidemics. And this is the rate per 1,000 in women who are not pregnant, and this is the rate per 1,000 in those who are pregnant. And these are the different influenza serotypes. And you can see that there is an excess rate. We've got here 22, 23, this is per 1,000, for those who are pregnant. So the point I want to make is that pregnancy is really a state of local and systemic immunosuppression. And that pregnant mothers, and this has been demonstrated, I mean, obviously with the H1N1 pandemic, but also with seasonal influenza, pregnancy is a state of immunosuppression because obviously in terms of actual rejecting the fetus, there have to be huge physiological factors, both locally and systemically, to immunosuppress. So the mother obviously doesn't reject the fetus. So the point I'm trying to make is that should be a strong motivation because pregnant mothers are obviously at greater risk of, if they do acquire many infectious disease, of being worse off. Influenza vaccination, we haven't touched on, but that's really protecting both the mother from what I've just said, but also from the infant. And as you know, we would recommend influenza vaccination for pregnant mothers. So this is data from Australia, the top one, and this was during the H1N1 Influenza A pandemic. This is data from Victoria, Australia, and what I put up there here really is just a count of maternal and fetal death from Victoria. But this is a systematic review, and this covers, each one of these lines represents a study, and this looks at fetal death after mothers who have acquired influenza. And if you're right of the line, there's an excess in deaths, and you can see for most of the studies looking at fetal outcomes after maternal influenza that there is an excess of fetal death. This is just one of the studies, and this shows the effectiveness of influenza vaccine. And this shows both controls and influenza, and this is one of the few randomized control trials, and you can see in terms of the neonatal outcomes, the differences in the infants in terms of those who were vaccinated and those who weren't. That is the mothers who were vaccinated. This is very recent data from Western Australia. So a lot of the data that we get for influenza vaccination, both from a safety point of view, but also from an efficacy, comes from Western Australia, because they've had a very active and state-funded immunisation program, particularly for the infants. But this is their data. It's not a randomized controlled trial, but it's simply looking at basically infants hospitalized for respiratory infections. So we're not even talking about influenza. This is just all respiratory infections in newborns. It's a cohort study, and it's looking back at the rates for vaccinated and unvaccinated mothers, and you can see the difference between the two. And for those who are more statistically inclined, you can see the odds ratio here being less than 1, which means it's protective, and these being significant across the studies. We've already touched on pertussis, and this has been mentioned by Lynn, but I really just want to emphasize the point that pertussis infection, in terms of mortality and morbidity, in a developed country like Australia, really affects infants under 4 months of age. So this is a 17-year retrospective study, all ICU admissions, 373 over that period, 84% less than 4 months of age, and 88% less than 6 months of age. So you can see the greatest burden for ICU admission under 4 months of age. 55% required respiratory support, 23 deaths, but important, 20 of the 23 were less than 4 months of age. So the point to make here is that those infants have not had the time, obviously, to be immunized. So this is why this cocooning comes into it, and also why maternal immunization is so important. And it's just to emphasize that I think cocooning is a really difficult and less effective than maternal immunization. In terms of actually does this work or not, this is a case-controlled study from the UK. There are not a huge number of cases in this particular study, and this really takes a case of pertussis presenting in the neonatal period and then looks back to see whether the mother has been vaccinated or not. So, and then it's looked at, and then by doing that, you can actually calculate your vaccine effectiveness. And in this particular study, they had very high rates of vaccine effectiveness, 91%. I want to move on to safety. And just like I mentioned, that immunization of pregnant mothers was recognized very early on to protect newborn babies, safety of vaccines has been a concern since the onset of vaccination. So I don't know how many of you have seen this cartoon, but it was actually came out 4 years after Jenner's experiment, and it was published by the anti-vaccine lobby at the time. And what this depicts is Jenner vaccinating, and then cowpox lesions or cow lesions developing in the vaccinated subjects. A very, very famous cartoon from the time. I want to make this point that when you ask pregnant mothers why they did not receive the influenza vaccination, and again this is from the MMWR, is that safety comes out as being more of a concern to mothers than efficacy. So it's really safety that we need to convince many mothers on. I'm going to just give you some brief snapshots of the safety data around pertussis vaccination. So pertussis vaccination for pregnant mothers really was taken up big time in 2014 and before in the UK. And this is really their safety data. It is observational data. In other words, this wasn't a randomized controlled trial. This simply looked at vaccinated and unvaccinated mothers and looked at many of the outcomes that you would be interested in as midwives and obviously as obstetricians, and that is stillbirth, neonatal death, placenta previa, cesarean section, premature labor, postpartum hemorrhage. The numbers in each group are in the thousands or tens of thousands, which is always reassuring from a safety point of view to know that many people have been immunized. And the only one that I just highlight for interest is actually the preeclampsia and actually a reduction of risk. So you can see that when you match that to controls, 0.67 for the vaccinated, which gives a risk of 0.52, which is significant. So a curiosity, and to say that even immunization may even protect you against some of the adverse outcomes. This is a much smaller study. This was a randomized controlled trial, and this did use a placebo. And the point I want to make here is that if you just look at fever, if you look at the immunized group, so these were mothers who were immunized during pregnancy, so antepartum, you've got a 3% rate of fever. Whereas if you look at those who were immunized after pregnancy, 26% had fever, or if they were non-pregnant, 9.4%. So I'm trying to make the point that for many of those systemic effects, that in fact the adverse, what I would call side effects really to vaccination may be less common. And I think that does tie in with pregnancy being a relative state of immunosuppression. But this is what parents are going to, or that mothers are going to ask you, how do you know anything is safe? And you cannot prove safety. That is the issue. If you get on a flight, I can't prove to you that that flight is going to be safe. What I can prove to you is that there are no adverse events or adverse reactions that have been detected or found. And that's what we're really looking at, adverse events and reactions. Now, this is really what changed the world in terms of pharmacovigilance, and I'm sure many of you will recognize the structure of that molecule. The actual structure of it actually depends whether it's teratogenic or not. So this is obviously thalidomide, and prior to the thalidomide disaster, there was no such thing as pharmacovigilance. So thalidomide was used and registered without any animal experiments or any real human experience as to safety. So pharmacovigilance and pregnancy really go hand in hand. That's where it all started. There's an interesting Australian connection, and that is that this person is Dr. McBride. He was an obstetrician in Sydney, and he wrote this simple letter to the Lancet, I think, which was only one paragraph, but changed the whole face of pharmacovigilance, because he again, like the Zika story, noticed this phocomelia in a collection of children. So we know there are FDA pregnancy categories, and I won't go through all of them, but the big issue in terms of safety and assessing that in pregnancy is that pregnancy often precludes involvement in clinical trials. So often, obviously, for drug trials or vaccine trials, pregnancy is often an exclusion criteria. Clinical trials may only occur for currently recommended vaccines in pregnancy. And really, if we look at the post-licensure, so once the vaccine or drug is licensed, how do we actually detect adverse events? Largely by passive surveillance, which is really reporting, and that has its own problems. So really, there's a call internationally for greater, I suppose, protocols of evaluating both drugs and vaccines in pregnant women. And this has been driven by the NIH, but also by the WHO. And also, if you're interested, by this consortium. So the Global Alignment of Immunisation Safety Assessment in Pregnancy. So I'm just trying to make the point that there's a lot of work going on internationally about trying to define better pregnancy outcomes from a drug and vaccine monitoring point of view. So in summary, as we know, coverage is really the most important factor. And it's been well shown in many vaccine studies that the knowledge and attitude of the health provider, which is really you, determines how confident parents or mothers are in taking up that advice. So you should be confident about the benefits, and you should know, obviously, the facts and knowledge around vaccination, both efficacy and safety. I think it's very important to engage all stakeholders. There should be communication around adverse events, and many of these, such as stillbirth, preterm delivery, congenital abnormalities, may well, of course, be coincidental events. And this is the big challenge, is really to really differentiate a coincidental event from a drug or vaccine reaction. And I think assessment on safety, there's a lot of work going on within pregnancy to try and do clinical trials better in pregnant women in order to provide the level 1 data that's required. Thanks very much.